What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
Kane, I'm happy to tell you we got another thrilling episode. A great topic. And that topic is radiculopathy. And whatever variety of radiculopathy you want, lumbar, cervical, thoracic, we're talking all of it today, okay? So let's start. I'm going to just go with our operational definition for today. When we say radiculopathy, we're going to use that term a lot throughout the episode. We are talking about pain in the extremity that is from a spinal source. We're aware of radiculitis. We're aware of neuropathic pain without nerve root compression. We're aware of, radiculopathy being that you would need a loss of function, decrease in power, sensation, reflexes, things like that. But just today, I think, and Kane, you let me know if you agree or disagree with this. I think when physicians, when referral sources refer to radiculopathy, they're talking about people who have pain in the extremity from their neck or their lower back, stuff like that. Is that how you interpret it, at least, in the United States and the system we operate in?
Yeah, I think that if you really want to split hairs and give a definition to a majority of the patients that we see, they are probably experiencing radiculitis. But I think everyone just overwhelmingly calls it radiculopathy or radic for short, because they kind of fall under a very similar category. They are all spinal sources of pain that are usually referred down into the extremity. But the biggest difference, I think, is usually just that for radiculopathy, you're going to have that weakness, you're going to have that disruption in sensation or something along the lines of that. And you may or may not have pain with that. So I think kind of classifying them under the same umbrella is acceptable, like if we're speaking clinically. But if you're going to be chatting with it or about it with your colleagues and whatnot, I think that that's where you kind of have to maybe be a little bit more explicit, like, oh, it's a case of radic, but they have a myotomal or dermatomal pattern that we're seeing. So that way you can definitely kind of tell like what the difference is. Or if it's just like something that's like really painful and symptomatic, then you can clarify that with your colleagues when you're talking about it. But for the sake of this episode, I think that radic is totally fine to utilize across the board.
Yeah, for sure. So where do we start? Like, someone's coming in, the referral comes in for, lumbar or cervical radiculopathy. Is there anything that before the patient even comes in that you're thinking that presentation wise, something the patient tells you subjectively, even maybe something you see in the chart review that would make you think, okay, this has the qualities of a radiculopathy?
Oh yeah, for sure. Like if I see a shoulder or a hip, I am not usually thinking that it's shoulder or hip unless it is there's an acute incident. But if it is like an ongoing insidious thing, I'm usually like, all right, we definitely got to rule out the spine here. There's a high chance that there is at least to some degree spinal involvement going on. The other thing
like you said,
that I'm
insidious, it's like, I don't know, like insidious in that they have extremity symptoms, but it doesn't match that. They didn't have any kind of mechanism. Is that what you're hinting at? Right. Okay.
Yeah, pretty much. Like there's no trauma or anything like that. And usually it's just like, honestly, if you take a lot of our previous episodes and just like combined tidbits, you're going to get a lot of what we talk about here. The symptoms are going to be variable. It's like, oh yeah, sometimes I can reach over my head and then other times I can't and it hurts a lot. Or like, yeah, I just feel like really weak, or I feel like I'm not stable, like something wants to give out on me. You're going to get a lot of those things where it's just like, oh, this doesn't really sound like it's a strength thing, because if you test them, sometimes they're just like they're like 5 out of 5. They have no issues with their with the actual isolated testing of their muscle, but when they're functioning in their respective I guess like more provocative patterns, that's when they're like, oh no, I feel weak here, or I this is where I have my pain.
Yeah,
So
and I like that you mentioned that, 'cause like I said, these functional patterns. Like I just had someone come in who it's yeah, so shoulder pain, actually, funny that you happen to use this example and they're thinking it's shoulder. Well, the only time they have the issues are when they do electrical work, and it's when they're trying to reach overhead when their head's forward, right? So you have them retract and they're reducing their symptoms, and all of a sudden their shoulder works fine, right? So like when I test their shoulder in the seated position, upright posture, they don't have the pain, or at least it's better compared to when they are noticing the symptoms. Or the reason they came here is when they're working with their head forward like that in that position. That's when they're symptomatic, right? So it's funny you hinted on that specific example, because it talks about, I mean, and we talked about this before, you need to be specific about your testing. You need to ask the right questions so you know how these symptoms are presenting. In this case, maybe you test the shoulder and it's fine, right? Well, I thought it was a shoulder issue.
Yeah, and I think that last part that you mentioned, where you're testing someone in specific patterns, it's actually something that I started doing a little bit more. I've done it previously, but now I am noticing that it is a pretty effective way of like helping to further screen out the spine. Is they're doing a motion, you've done your repeated motions testing, you're like, I'm just not getting what I want out of it. I'm going to have them do the same motion, but this time I'm just going to change the position of their spine. And so pretty much for Mark's example, the person's having symptoms, and let's say I can't make that change at all with like repeateds, right? So instead I have them fully protract and have them do the motion. They're like, oh no, there it is. I'm like, okay, now we got something. Have them fully retract and then do the motion. See what changes. That could also give you information about a directional preference as well. Absolutely. Too. Yeah. When you're approaching the spine. So just something that I know is different from the traditional MDT framework that we typically utilize, but still very telling of a directional preference as well.
Yeah, and we mentioned the XPOS study in our in a previous episode, or maybe multiple of our previous episodes, but that's one of the criteria, right? Changes symptoms with spinal movement, right? So like you talk, like, I use the example, right? If you have someone like, without getting too far off base, let's say you're just testing shoulder again, right? Let's say you have them in that retracted position and they're asymptomatic, and then you go into protraction and all of a sudden it's symptomatic, right? All you do is change the position of their spine. The shoulder's still in the same testing position, but we notice a symptomatic response as you change the spinal position, which can be an indicator of spinal source of pain. Radiculopathy, perhaps, as we're discussing this in this episode.
Yeah, and I think that's kind of it's something that we can definitely check in with our patients as well too, to kind of see like, hey, have you noticed that doing different activities changes your shoulder pain or your hip pain or anything along the lines of that those like postural changes, I think that is going to give you a little bit more insight. Like that already checks off one of the aspects of the criteria that we use, right? Which is like changes in symptoms with spinal motions or postural changes. I think that is definitely really telling of a potential radic that we might be uncovering. Because, let's face it, how many times have you gotten a diagnosis from a physician and they say that's shoulder, they say that it's hip, they say that's knee or whatever, and then have them do a couple of repeated motions and they're like, oh, I feel way better, right? It just kind of goes to show that, hey, when you're trying to figure out what's going on, don't take the diagnosis at face value. Make sure that you are really figuring out whether or not you're dealing with a spine or if you're dealing with like an actual extremity issue. I think that's so important when you're getting your subjective from your patients. All right, Mark. So, what else do you really take note of when you are working through the subjective? Any other questions? Any other like key
Right. Yeah.
tidbits that you're really trying to draw in from your patients?
Yeah. This is something we've talked about just on our own time, and something you've mentioned in a previous episode, which I also noticed about the quality of pain. Right. That burning, of course, numbness, tingling, that electric shock type feeling. Right. These are, for lack of better terms, like nerve quality type pain, which we can are signs of radiculopathy, right? So compared to if it's something where, and this can be variable, right? But if it's something where we're thinking more like joint related, like maybe just like a deep ache, right? Like a clicking, popping, like mechanical type symptoms, which we're still not ruling out spine at this point. We still need to test it. But if someone comes in and like, oh yeah, no, like I can think of someone who has lateral couple cases recently, or at least within the last year, lateral elbow pain. The referral is tennis elbow, lateral epicondylitis, right? And oh, I really feel it a lot when I sit, and it's burning, right? Well, I mean, of course I'm going to look at the. Right, I'm looking at cervical and thoracic easily at that point, compared to someone who told me, I only ever feel it when I use it, and if I do too much, it hurts more. But if I use it the regular amount, it just hurts, and then it goes away immediately after. I mean, more questions to be asked in that case, and we're probably still going to rule out spine and test it. But compared to the first presentation where it's only sitting, my grip's fine, and it's a burning type quality. Yeah, that's something else. So the quality of the pain, how the patient's describing it, their interpretation of it, and that to me gives a lot of information. I also like, using that example again, when they're feeling the symptoms, right? I know you talked about not putting a lot of weight into the diagnosis that they're being referred for, but like they've had an assessment from someone at some point, right? And the patient's understanding is that that's what's going on, right? So let's just take the elbow example. They probably look it up. Oh, tennis elbow. I don't play tennis. Yeah, right. Most of you guys don't. All right, sorry. You have pain on the outside of your elbow. That's fine. Well, I looked it up in Google, and it says, it hurts when you grip and carry stuff. Like, mine doesn't really hurt. Mine's really just if I'm using the computer for too long, something like that. They've just opened the conversation up for, okay, hey, it could be this, it could be that. It could actually be something, coming from your neck. Let's test it out. This is probably this is the standard of care anyway to test the spine. And then said you're kind of coming to an agreement with the patient. This is what we're going to test. And then depending on the results, however the result, depending on the results of the testing, it's going to dictate your management strategy. But yeah, just making sure you're investigating the symptomatic presentation, the quality of pain, to me is a big part of the subjective.
Wait, do you really think that standard care is going to check out the spine for most people?
I don't think so. I think at that point, we're busting out the radio frequency calibrated special Graston tools, and we're throwing on a little bit of goo or whatever that white cream's called that I haven't ever touched. Because guys, listen, it stains your clothes. You can't get it out. Don't even think about touching it. All right. Anyway, the standard care I think is some manuals, massage, instrument assisted stuff, and wrist and elbow strengthening. I was saying that I should have said that when I said standard care, I should have meant that like the standard of care should be to screen your spine.
Okay.
That's
What
my standard of care.
I wasn't sure.
Yeah, no. Good point, man. Good point.
Thanks for
keeping me honest.
I was like, wait a second. I don't actually know a whole lot of people that are going to see a presentation like that and inquire further. They usually are just like, oh, you have lateral elbow pain. When you sit and use the computer, it must be lateral elbow pain.
Yeah.
And so I think that this kind of is a bit of a wake-up call to get people to start checking the spine more, to start paying more attention to what their patients are saying. I have one. Just going to be so helpful.
One more from the subjective that I may have personally observed is that, and this is just generally, but if someone comes in and they're reporting bilateral, symmetrical symptoms in both extremities. Bilateral elbow pain. Oh, it hurts in the back of both my shoulders, both my shoulder blades. On the back, both of the bottom of both my heels hurt. I got plantar fasciitis on both sides. I think the bilateral presentations screen spine, or at least it should be screened, right? It should be addressed. It should be tested. What do you think of that?
Yeah, like what are the chances that something pops up, like multiple issues pop up at the same time? It's just like if someone comes to me and they're like, I remember I have this patient right now who's like, oh, I have like bilateral hip pain, knee pain, and Achilles pain. I'm like, are you sure? He's like, yeah, it really hurts. I'm like, you have a history of back pain. Did this change the last time that you were seen for your back? And they're like, I don't really know. Maybe a little. I can't really tell. I have him move his back around. And he's like, oh my God, like most of it's gone. I'm like, yeah, I don't think that you could have 2, 4, 6 different issues popping up all at the same time. What are the chances that that happens, that you're going to have 6 tendinopathies just magically appear?
Your body's just revolting. Yeah.
He's like, I didn't even do anything different. I'm like, yeah. I don't think that you needed to, right? Like this isn't an actual like tendon loading issue. This is just an issue that's coming from your spine. So when you have things that are popping up concurrently like that, I think that is where you definitely got to make sure that you're checking the spine. It just makes more sense that you're going to have more issues coming up from one root cause than to have several different issues that pop up together. Sometimes it'll happen, but from what I've seen, it's usually not the case. So one thing I do want to touch on before moving on is the quality of pain that Mark talked about. So he talked about burning pain, numbness, tingling, sometimes getting like that electrical kind of feel. Those are definitely screaming nerve to me, right? But there are also so many other presentations that can happen when you have Radic, like especially for lumbar. I have seen so many people where they're like, yeah, it's just like it's achy all the time. It's super sore. It feels like it's tight. Anything along the lines of that. Sometimes you might even get sharp pain depending. They might not be able to differentiate between sharp/stabbing versus like electric. So remember that just because you're not getting the typical like characteristics that kind of point towards nerve related symptoms, like Mark said, the burning, numbness, tingling, and then the electric types of sensation, those can still be symptoms that you get from Radic. Just because they aren't nerve related does not mean that you can't still feel that. That's kind of the, I don't want to say it's like the beauty of Radic, but man, it just shows up in so many different presentations. It's so varied. Like you really have to appreciate and respect how different each presentation can be. And that's just one of the things I want to point out, is so that way we don't just hear some of those descriptors and write it off like, oh no, that can't be spine.
Well, I think it's telling, like you said, the beauty in it, but it really is, because we live in a world and we operate in a healthcare system that's based on diagnosis. When like you have such variability in a presentation, it just further emphasizes that a specific diagnosis doesn't matter as long as we have a standardized, accurate, and reproducible, repeatable assessment. That's what's going to lead us to the appropriate management strategy when you have such variability in a presentation, right? That has the quote unquote same quote unquote cause being radiculopathy. So
go ahead. I think that really highlights kind of why we got into creating this podcast, is to be able to discuss the nuance of these things. And man, Radic is just such a nuanced topic. Like these tiny little ins and outs really, really make a difference. Like what their presentation's like, how they're responding, what they responded to, and what exactly did you do to create some of those changes. That is like where I see so much like room for improvement in regards to myself, for other clinicians, and how we can improve our practice when it comes to identifying and assessing and then treating symptoms similar to this, where it's just like, hey, sometimes like those details, they do matter. And for people who have been keeping up with Mark and I's discussion, I think you guys can appreciate the fact that Mark and I, like, when we talk about things, we don't get hung up on details for the most part. But for cases like this is where it's like sometimes those details really do matter. So we just gotta pay respect where respect is due, because Ridic is not always an easy or cut and dry case.
Yeah, yeah, like the details, especially in the stubborn type cases, like we have a mutual understanding that we've exhausted planes of movement in the spine, things like that. So maybe we're talking about more nuanced type details, like, okay, what is the very most distal symptom? Is there numbness, tingling? Like, is that very distal symptom changing anyway? Do you have any hints of directional preference or centralization? So, yeah, it can become complicated, but when you have, like I talked about it again, I'm going to say it again, when you have that standardized assessment, when we're speaking the same language and we can be on the same page with things, it makes care more efficient, and you can communicate better with other clinicians. All right, we talked subjective. Kane, objectively, the person's starting to move, you're watching them move, you're looking to test different things. What are you seeing in the objective presentation of radiculopathies?
Whoa. Before we jump ahead,
I'm in trouble.
Mark, you forgot about the XPOS.
No, listen, I mentioned it, man. I don't want to get, listen, we like the XPOS. We're XPOS people. We're XPOS bros, all right? But, we talked about it. I mean, listen, like we said, if you got symptomatic change with posture change, with spinal movement, the extremity joint, the affected extremity doesn't have limited range of motion. They have numbness and tingling, all those kind of things. They're cluing you in. It's got clearly the source of the pain is in the extremity, right? Like all these things that you're looking at to add up to build your case to further investigate the spine. You want to touch on XPOS at all?
Nope, that's all I wanted from you was just to go through that criteria. I think it's so important for people to understand that if you are fulfilling the XPOS criteria, you are able to efficiently diagnose patients way faster in knowing that it's truly a ridic. And then from there, your game plan is pretty straightforward. You just got to figure out where you need to move. One thing I do want to touch on before we head on to the objective portion is that when we are assessing spine, right, for radicular symptoms, these symptoms do not necessarily have to cause back pain. They also don't even necessarily have to be painful in general, right? So there are some people who just come in and they're like, I have weakness, or like I have like some numbness or tingling, but no pain, or like they have like isolated joint pain. Like sometimes radicular symptoms we usually think about, at least I do, is that usually follows the path of a nerve. It's usually traveling down a limb of some sort, right? But there are cases where that is just not the case. Where they can just have pain at their ankle, they can have pain at just their knee, or maybe in the middle of their calf, right? And that is where we should really, really make sure that we're doing a thorough job and making sure that our assessment effectively screens out the spine just to see if that is a problem or not. And if it's not, we can move on and address whatever other deficits that you see.
Exactly.
What are your thoughts on that?
You brought it up, I can't help myself. But yeah, you don't have to have pain in your spine to have extremity pain coming from your spine, right? It just because spinal pain isn't present, it doesn't mean that your extremity symptoms aren't being caused from they aren't coming from the spine. So it warrants further assessment. Maybe you have a move, you're seeing movement loss, you have them do different things, and it starts to add up. But yeah, that's a big thing. People like come in and they have pain in the back of their thigh, and the therapist asks, "Oh, do you have any back pain?" And the patient says, "Oh, no," and that's it. There's no more assessment of the spine. They don't have back pain. It's not a radiculopathy. It's their hamstring or it's peripheral nerve tension or something like that. So I like that you brought that up, and it's an important point. Just because there aren't spine symptoms doesn't mean that the source of the pain isn't from the spine.
All right, so now we can finally move on to
All right.
the objective portion.
Exhale.
So I think the main things that I'm usually looking for during the physical exam is limitations in their actual motion for their spine, not necessarily in their extremities. Sometimes we'll see it where it's like, oh, they're limited in their shoulder flexion or abduction. Yeah, have them move their spine and boom, it's fully restored, right? Sometimes you'll get that, sometimes you won't. But one thing that I'll say for sure is that when you suspect a radic, you have to check the spine. You really should give overpressure if you're also not noticing that there's any symptom presentation. If you have them move into extension or into flexion, they're like, oh no, it feels good. And then you give them overpressure and they're like, oh no, that recreates my pain. Guess what? It's probably telling you that something's going on there, right? So make sure that you're really flushing this out. This isn't something that you just kind of skim over, because I know it's very easy to just be like, oh, look up, look down, turn.
Yeah,
Okay, awesome.
yeah.
Looks good.
And I
Right?
want to
But
touch on with that too is like, and I wasn't, I think it's important to look at where the movement's coming from. Like if you're suspecting a lower cervical radiculopathy and you ask someone to extend and look up towards the ceiling and they're only extending from upper and mid cervical and they still have like that kind of upper thoracic, lower cervical kyphosis, well, we're not properly assessing the end range extension movement of those lower segments. And I don't think if they don't have the mobility there and you're not asking them to really open up and even use the back of the chair to get some leverage to go backwards, I don't think those segments are getting properly assessed. Do you look at the quality of movement? I mean, the same thing you can see with lumbar sometimes, where it's like someone has really good hamstring mobility and they just hinge and they're staying neutral spine while they're touching the floor. Well, we're not properly assessing lumbar flexion in that case.
oh yeah, absolutely.
Yeah.
I mean, between the two of us and how I utilize motor control, I think that I 1000% check to see how they're moving. Just like what Mark said, like I'm seeing where the motion's coming from, right? Like when you are extending for your cervical spine, you should be getting motion everywhere. You should be seeing your upper thoracic moving as well too. And if you're really someone who's mobile, it can even go down into your mid/lower thoracic if they're that mobile, right? So it's just like understanding like, hey, are things moving how they kind of should? Because like for lumbar, it's the same thing. Like what Mark said, if someone hinges and they only extend from one spot, that's kind of telling me that the position that the vertebrae that are above and below, those guys aren't moving super well. Maybe if I have them extend and they just do it the way that they normally would default to, that's not the solution. Maybe it needs to be a little bit more focused and targeted to address those segments above and below to see if that's where they need to work on their mobility. And that's what we're looking to address, right?
Yeah, for
sure. So I definitely do take a look at that. And I think it's so important to assess, because sometimes when you are going through a repeated motions exam and you are like, I'm doing the extensions, I'm doing the retractions, I'm not getting anything. Maybe it's because they're not getting the motion where they need it the most. Maybe they're already getting the motion from a spot that is too mobile, and that's just not going to fix anything, right?
Yeah.
So making sure that you're like tailoring it to your individual patient is just, I think that that's going to help a ton of people for problematic cases.
Yeah, which it's a pretty nuanced type thing. Like, I mean, we can stick with cervical example. Like maybe some people just have such little retraction mobility that you might even have to change the angle and have them flex a little bit and then retract into flexion. And then eventually they can get to a more neutral spine position and you can start to retract while they're looking straight ahead. But yeah, I don't think, we're not going to dive into it too much. But yeah, looking at the quality movement and making sure you're just working into the area, getting some mobility from the segments that you think are causing the symptoms it's an important aspect of the objective exam.
Yeah, and the one thing that I do before we move on, I think that's so important is you're gonna run into some patients that, Mark, I'm sure that you've seen this a bunch,
Mm-hmm.
which is when they retract, they just run into themselves.
Yeah,
They
yeah.
they move into a little bit of extension, and you could just see their vertebrae just like just
Trembling.
boom every single time they retract, and they're like, "Oh yeah, that hurts. It pinches."
Yeah,
I'm like,
ouch. Me too,
yeah,
man. Me
yeah,
too. Yeah.
see that." So then one of the things I usually have to do for these patients is I tell them, sit straight up. I want you to be as tall as you can be. And then sometimes you have to manually guide these
Guy,
people.
yeah, for sure.
Maybe
Yeah.
they've been in pain. Maybe they've been in pain for so long that they are struggling to actually move or understand how to move again. And so that, I think, is like, when you see something like that, that does not necessarily mean that repeated motions doesn't work for them. Maybe it's just that you have to cue them appropriately. You have to make sure that they're doing the repeated motion correctly. Otherwise, yes, they're probably just going to be slamming into their facets again and again and again, which,
Yeah.
yeah, I think that that'll be pinchy for anyone.
First, yeah, not the desired, not the desired outcome we're looking for, right? So, yeah, make sure they're doing the movement correctly for sure. How about, so we talking about a single movement? I mean, there's value in doing the movement once, but I think doing it repeatedly is going to give you better information going forward. Like, how do you assess a single movement, and how do you assess it repeatedly or even sustained?
So, um, the funny thing is, I had a coworker point this out recently during an eval, which is when I have someone go through a single motion for their spine, I'll have them bend forwards first, and I have them stay bent forwards, and they usually take their time. They're trying to see if they can get down further. I will literally bend forwards right alongside with them and have a conversation with them. And be like, "Hey, how does this feel? Are you getting any symptoms? Anything running down your legs? Is this as far as you normally would go?" They're like, "Yeah, it feels good. It feels okay." And I'm like, "Okay, hang out here for a little bit." And then if there are no symptoms, I give them overpressure. But the fact is, I'm having them sustain in that position just for a little bit longer. See what's going on. Like, if I just have someone move one time, they do it fast, I may not get what I'm looking for. If I give them a little bit more time, see if they loosen up, see if they can continue to get further, see if that is what spurs on their symptoms, that's going to give me more information. Same thing goes for when I move them into extension. I'll offer them like my hand to just support them. It's gonna be there if they fall, but I kind of keep my other hand over top of their torso, so that way they don't get the urge to stand up right away. I kind of keep them there for a little bit and see, hey, what's going on here? Are you feeling anything? And people are just gonna be responding while they're in that position. And
Yeah.
that's usually how I get a lot of additional information of like, hey, is this something that we need to move into? What about for you, Mark? Do you usually just have someone move through one time? Do you have them move through like a couple of times to see if they loosen up, or what's your order of operations
Yeah,
here?
I try and like, I mean, standardization is, I think, for me, key. I think, just generally going forward, it's important for people who want to learn and for the efficiency of patient management. But I try and do so I try and standardize. I try and keep it the same with each patient. So I'll do a single movement in each plane of movement first, and I'll gauge
Yep.
the symptomatic response. I've already gotten my baseline symptoms. Hey, when you did that once, how's it feel? It hurt. You feel it afterwards? It's how it was, right? So I get that response, and then based on the subjective information and the information from the movement screen, where I'm having them do each movement once, that guides the next portion of movement, which would be doing these movements repeatedly. Like I said, based on the information I've already acquired, will determine which movement I start with. I mean, typically, you're not getting the most important information just from the single movements, right? Maybe someone does a movement like, oh, it feels better. I don't think you know that they're going to have a long lasting, noticeable response until they do it repeatedly to end range or sustain the position to know that they have a lasting positive response. I mean, sometimes you may have someone do a movement and say, oh, it feels good, and then they keep doing it and it gets worse, right? I mean, you might have the opposite, right? When you have movement, an obstruction of movement, your symptomatic response may increase initially, but as you work through that obstruction, it may decrease and stay decreased afterwards. So you get the most information from the repeated end range movements, in my opinion. I'm sure you address it similarly. Yeah.
Oh yeah, for sure. So I am definitely a big proponent for the standardization of an assessment or a physical exam, whatever you want to call it, just because that way you can make sure that what you're doing is consistent and reproducible. If you continue to vary things over and over again, you just don't know what you're going to get. You don't know how lit up someone is. Like if their symptoms are very irritable, then like, hey, maybe moving them like twice is going to be enough to blow them up, right?
Yeah.
But yeah, I think that that's definitely something to take a look at. Now, the next thing are things that I think that a lot of people do not look at, right? It's something that's built into my exam. I mean, I will say I am definitely guilty of not always checking reflexes, but man, I do not see a lot of people consistently checking myotomes, dermatomes, and reflexes.
That's me.
What do you usually do for spine patients?
So let's start with myotomes. I do myotomes, and I think it's just because, yeah, I want to know where their strength is at, where their power is at. At least for me, if I find a certain myotomes affected, it's higher up on my list of baselines, and it's something I want to address, and also leads me to believe that, radiculopathy is on the table, right? Along with the other information I've gathered from the subjective and the objective exam. Dermatomes and just sensation in general, unless the patient has specifically told me they have numbness in a certain area, I typically do not test it. And my reasoning for this is that the sensation from a baseline and testing standpoint, in my opinion, it's not high on my list. And I don't find sensation testing, and to be fair, I don't do the, I'm talking light touch. I'm not talking about using, or like what are the, I have them in the clinic.
Monofilaments.
Yes, like I know you can quantify it, and maybe those are reliable, but I think when you're testing sensation with light touch, I don't know how reliable it is. You know what I mean? So I typically omit it, and that's in the case when the person has told me they don't have, do you have any numbness or no? I can feel everything, and typically they have other symptoms. They have pain, maybe they have tingling, maybe they have weakness, they have functional limitations. All those things are way higher up in my list of baselines and things that I'm going to look to change and test and retest, especially compared to, if they have a little bit of numbness on the bottom of their foot or something like that. Now, on the other hand, if someone comes to me and their primary complaint is numbness on the outside of their thigh or wherever it is, of course I'm going to test that, right? Maybe even if they have other symptoms, if they're subjectively reporting it and it's important to them that this numbness is addressed, I'm testing dermatomes. Maybe I'm going to test peripheral nerve patterns, things like that. Yes, but when we have a whole bunch of other symptoms that, in my opinion, fall higher up on the list to be addressed and are a little bit more important and a little bit, are a bit more telling when it comes to retest in terms of if the patient's improving or progressing. Yeah, dermatomes aren't really, they fall way lower on the list, and I typically will not test it unless it's subjectively reported. Reflexes I do just as a part of the neuro screen, right? I mean, if I, start to see like upper motor neuron signs or something like that, yeah, I'll test it. But another kind of test, like I don't know how reliable it is when you have someone come in and they have back pain and leg pain, and their L4 and S1 reflexes are just zeros, and it's like, is it really zero, or is this person just guarding? And like, I don't know how reliable that reflex testing is on its own. I do it essentially just to test to see if there's hyperreflexia, and then once I do the S1 Achilles, I just hit him with a quick clonus test too, because I'm there. So that takes care of the red flag screening. But yes, the dermatome sensation, unless a person's telling me that, I'm typically skip it. But I usually do reflexes. I typically do myotomes. All right, let me have it, Kane. Let's hear it.
So I actually do agree with a lot of what Mark said.
You do? Oh, okay.
Yes. I still always test dermatomes. It's like, it's so fast. The other thing is, when I'm testing dermatomes, I am not testing it the way that like a neuro PT would do, where they're like, okay, how many times are they getting this accurately? Like, am I touching it? Am I not? Etc. Like, I'm not doing that. This is a gross screen to make sure. Does it feel the same side to side? Yes or no? Is your sensation intact? Yes or no? Awesome. We've gotten past that. That's fantastic. The other thing that I'll say that, and this is why I largely agree with Mark in regards to using dermatomes or a sensation as a comparable sign or as a baseline, is, I don't know about you, Mark, but whenever someone has numbness, that takes a while to usually get rid of. And I don't mean like numbness in like my thigh that follows the same path as like the other radicular symptoms. That usually goes away fairly quickly.
Sure.
I mean more or less like the isolated instances of numbness. Like, I still have numbness at the bottom of my foot or at my big toe. I'm telling you, those things take an eternity to go away. If you expect that to go away within your time of care, I think that may be an unrealistic expectation.
Yeah,
at least from what I've seen.
Yeah, the response I'll typically get when I assess these patients, and listen, maybe I'm missing something, maybe we're missing something, but is you have them do a movement and they're like, oh, maybe it's like a little better. It's like you're hitting these hard yellows that that can be misinterpreted as like kind of like a yellow trending green or a light green, but it's not like, oh yeah, it definitely feels better. In the case where you have just isolated numbness, right? Like it's I definitely agree with you there. It's kind of, I don't really see cases there where it's like the person comes back for their follow-up and like, oh, the numbness is gone. Maybe it's like, yeah, it's still there and stuff, but it's always a difficult, because the numbness is so subjective, and it's like, it's usually not functionally limits a person. Typically they don't know like when it started or what, they just began to notice it and it's kind of there, and it's just like, those cases are a little different for sure.
Yeah, it definitely doesn't tell me too much in regards to clinical relevance, unless like they just have entire dermatome is like just gone, right? Then I'm oh, like, hey, this is not normal, right? And then I think the same thing can really be said for reflexes. I don't put a whole lot of stock into it unless I'm getting an accurate reflex reading, right? Like, I remember I had a patient who I checked, one side was totally normal, the other side was very brisk, and she was coming in for low back pain with radicular symptoms, and I asked her, is that normal for you? And she's like, no, that is not. So guess who did the rest of the neuro testing to make sure that everything was all good? So lo and behold, I had her go through a couple repeated motions, reflex completely calmed down. Right. So it sometimes it gives you a good baseline to work off of. But once again, for reflexes, some people just have terrible reflexes. Sometimes it's an effective baseline. A lot of times I don't see it. But myotomes, I do think, are pretty effective. Myotomes are for sure, we'll check, especially to see like, hey, is there like what's going on here? Like, is it just weakness? Is it painful? Is it like that's where you can tease out a little bit more information just by talking to your patient about
Yeah.
like what exactly they're feeling.
Right. You talked about like numbness maybe being difficult to change if it doesn't follow like a specific dermatomal pattern. What about power? What about strength? If it does follow a myotomal pattern, do you find that can respond quickly?
Oh yeah,
Yeah,
it can be so fast. Like if it's something that is truly mechanical and something that I can change, like I have them go through a couple of repeateds and boom, like they change like by a couple grades, and I'm like, wow, that is definitely something that they can notice. It's something I notice for sure. I don't even say anything, and I'm like, how did that feel? They're like, no, it feels better. It feels way stronger.
Yeah,
I'm
yeah.
like, all right, that's the answer I'm looking for. There's my green light.
Right, yeah. And we want to make sure this will lead us into the next topic. Like sometimes you get that quick, rapid change and it lasts within the clinic. And it's almost like, you're second guessing yourself. Like, is this going to last to the follow up? So it's really important when you get that quick change, that's going to bump up higher in your baselines. And that's going to be important to retest. So why don't you, if you want, speak a little bit on, let's say you do have that quick change. You get the quick change in pain, quick long-lasting improvement in functional ability, strength, power. Do you have a certain way, or how do you go through about assessing and retesting these things when the patient comes back for a follow-up point? Like, do you follow a certain order? Do you feel like, do you just get right into it? Do you have them do spine movements first? What does that look like for you?
Yeah, so when I'm reassessing someone, I just straight up have them sit down. If it's their first follow up, for sure. We are just sitting down. We're having a little bit of a chat. I'm like, hey, what has changed from the last time that I saw you? And then they're like, I feel better or I feel worse. Then I'm like, how? What has changed? How are you better? How are you worse? Symptom wise, is it intensity? Is it the location? Like, is it your function? What are you talking about here? Like, that's where you gotta make sure that you're getting those details down, because when someone says better, it doesn't necessarily mean that it's better in the way that you may be thinking of or what you may expect. Right. So they could just be like, oh, yeah, my symptoms are way less compared to before. And then if you don't ask the question of where their pain is, maybe they say that their pain, instead of being in their knee, now it's down to their ankle. But you didn't ask that, right? So those are the things that you have to make sure that you're not just assuming things, that you're actually getting into those details and clarifying all the little bits and pieces. I tell every single one of my patients, like, hey, like I need you to be specific here, and I'm going to try my best to do the same, because we need to be on the same page, so that way I have a good understanding of your symptoms and where to move. But once they tell me these things, that's when I check in. Okay, how have your exercises been going? What have you been doing for it? Have you been keeping up with it? Staying with the dosage that I gave you, and etc. Right. And then checking in to see what activities are they doing? Can they do more? Are they able to tolerate it for longer? Symptoms are not coming on quite as strongly following. Those are all the things I'm typically looking for. And then we jump into the actual like reassessment or mechanical exam portion of the first follow up.
Yeah, I think an important part of that is you have your baselines that had the most amount of change that are falling higher up on your lists of measurable and accurately testable and retestable baselines. I think an important aspect of that when it comes to the follow-up is these things changed. We sit, we talk, how are you feeling? You any different as a result of doing the exercises? And then we're taking those baselines, whether it be strength, whether it be, we talked about like sensation, whether it, pain, range of motion, and without doing any kind of treatment or repeated movements or sustained positions, we're retesting the baselines, right? It's a baseline for a reason. It's what their presentation is like without doing anything, right? So if they've been doing their, whatever exercise you recommended to them, and they've continued the same kind of activities they've been doing that they were doing previously, where they were symptomatic or had, more symptoms, and now you retest and things are improved. Yeah, the only thing you change is the exercise you recommended. Everything else stay consistent. We can say that we can definitively, maybe they have told us they're better, but we can objectively prove that they're better as a result of this, and we can expect it should continue. So I think for radiculopathy, it's important to retest the baselines after speaking with the patient before you have them do movement, stuff like that. Because you know what I'm saying? Let's say that, the reductive movement was, repeat extension lying. You come in, they say, oh, I'm better. Okay, here, give me like a couple rounds of 10 of that. And then you retest again. So, oh, it's better than last time. We don't know what the new baseline was, right? Maybe it was worse, right? I don't know, right? It's all about standardizing the testing. I think doing the testing the baselines first is really important.
Yeah, and I think going off of that, one of the things I definitely want to stress and get across is if your patient is that much better on the first follow-up or second follow-up, whatever, and you can't find or their previous comparable sign is like no longer causing them any provocation of their symptoms, you need to find a new comparable sign. Like, you have to have something that you're testing it against. So when someone is telling me like, oh yeah, okay, so I can get up and down from a chair better now. Okay, awesome. What happens if I have you bend forward and pick something up now? What happens if I give you something to load that squat? Does that change anything? Are they able to go up and down steps without any issues compared to previously? You have to find something, anything, because then you can actually compare to see whether or not the repeated motions that you've given them is still effective. Or if you need to progress them, you need something to test when they're coming back in. So if you don't have, or if their previous comparable sign is like all good, you got to make sure that you find something else to go off of, right? Something usually functional that they encounter in their day-to-day life, I think is like probably one of the most important comparable signs that you can generate, because it's going to be salient to them. It's going to be, oh, I'm going to come across this. I'm going to see it again and again and again, so I can keep a good eye on it. If it's something that they do once every like 3-4 months, like what good is that going to do, right?
Relevance,
Yeah, or if it's something that you specifically put them into this position or whatever, then I just don't find those to be quite as effective. But if that's the only thing you got, that's the only thing you got.
Yeah, you got to work off something, right? I mean, you need to know. You need to have something to compare. It needs to be measurable. Like I said, it's got to be relevant to the patient. So finding something that's retestable, that you can use as your baseline, is really important. So, Kane, we haven't mentioned this explicitly, but when we were talking about our objective and then movement assessment, stuff like that, we're really talking about MDT, repeated movement, sustained positions. Like, why, when we're talking about this radiculopathy episode, like, why do you think we're kind of defaulting to that? Like, and I know you and I, that's, I have formal training in it. You have had a ton of exposure to it, and with some like mentorship and things like that. Just in your experience, like, do you find it to be effective in treating this radiculopathy presentation?
Man, I'm telling you, if you can find a directional preference for someone with radic, that is your golden ticket. Like, I don't know how else to explain it. We've talked about it previously. If you find a directional preference, you need to ride it out. Like, that is such a fast and effective way to pretty much resolve so much of their deficits without having to do anything else. Because I don't mean that as being like, oh, I'm a lazy PT. I'm only going to give you one thing and nothing else. I'm saying that from like, you can control all of the variables here. You can't do that for a lot of other interventions. But with directional preference, you are in full control of knowing this is what I gave the patient, this is the dosage that I gave them. And then as long as they're compliant with it, now we can really see, okay, is it having an effect? If it does, awesome, keep going. If it doesn't, what do we do? Do we progress? Like, how exactly can we move around this new obstacle? But for other things where you just can't quite control all the variables, there's a little bit more room for uncertainty. But when it comes to directional preference and Radic, man, if you find it, please hammer it home. Like, crush that homer. It's right there waiting for you, man. So I think that is probably one of the biggest reasons why I continue to use the system, is because it is so effective at diagnosing, but also addressing a lot of ridiculous symptoms. I don't know about you, Mark, but like it tells you what you need to do and where to go. And even if it isn't like an MDT based exercise, it still tells you like, hey, you just got to exercise them. You just got to move them. And then you're probably going to see some changes, and then you can potentially reclassify them.
Yeah. I mean, I listened to a podcast recently where they basically had a manual approach, but they were using manuals to get joints to end range, and they were testing with that. Like, I think you need some kind of system where you're testing end range movements and then gauging the response, testing and retesting your baselines to know what's improving or what's changing, and then that just dictates your management. I think if you're treating spine and you're treating radiculopathies and you're not utilizing a method where you're working to end range repeatedly, I think you're missing a component of the management. And like, I mean, Kane and I will be straight up when we say this. Like, we're not saying that these management strategies have, superior 5-year-long outcomes compared to even doing nothing. But I mean, yeah, maybe there's some issues with like the study data and things like that. But I just think in terms of like building good, solid therapeutic alliance, getting buy-in, and then being able to show a patient that they can manage their symptoms independently and know what to do if they comes back is a key in treating this population. Kane, anything else you want to add?
I don't think so. Not yet. Anyways, not yet. Yeah. So that kind of gives a little foreshadowing, and the fact that there is definitely going to be a part 2 on this. But I think we got a lot of stuff out there in regards to like what to kind of look for, and then the next episode is going to be, I think, a good one in regards to insight for what different presentations can look like and how to proceed from there.
Exactly right. So yeah, definitely look out for that one. We'll talk about different presentations, how we manage it, and hopefully it's something that can help people clinically. Okay, just to wrap up, we talked about radiculopathy today. We understand the academic definition has to do with like a loss of function, whether it comes to a decrease in sensation, a decrease in reflexes, a decrease in strength or power production. Today we're talking about extremity symptoms of spinal source, right? There's other terms that meet different criteria, definitions, radiculitis, nerve root compression, things like that. Radiculopathy is something that other providers understand. That's what we stuck with. Things that people tell you when they have that may clue you into radiculopathy. They have extremity pain, but they don't have limited extremity movement. Maybe they have a lack of spinal movement. They have pain at rest. They have change in postural and change in extremity symptoms with spine movement or posture change. The quality of the pain is like a burning, numbness, tingling, an electric shock type thing, all things that should clue you in to look at the spine. Objectively, maybe they have limited spinal movement, and they will typically, if it's tested appropriately, have some kind of lasting effect from repeated end range spinal movements. We talked about looking at myotomes, neurotomes, reflexes. Yeah, all things you can look at. Depending on the presentation, it would have varying importance in your building your case for management. In terms of assessing and follow-up, it's utterly important that you have good baselines and that you're able to consistently test and retest them so that you know the patient is improving appropriately. All right, that concludes today's episode of the PT Good Podcast. Remember to leave us a like, subscribe to us on whatever platform you're listening to us on, follow us on Twitter at PT Good Podcast. We thank everyone for listening. Hope you enjoyed. We will see you on the next episode.
We still love you. Bye.